Good morning, everyone. Welcome you all for the another wonderful session today. I hope you all are enjoying and attending all our sessions with AAPC local chapter Abu Dhabi. It's very happy to see you all in another fine morning today. The topic today is for a dental coding series part one. There is a reason why we keep it a series one actually because we are planning to keep one more session on dental coding this year. We are looking forward. Medal is spending a lot of time in preparing the slides and adding a lot of wonderful points, and that could help all our coders here in Abu Dhabi. So that's why we keep it as a part one, so that we can expect one more session within this year. And regarding the speaker, I think I no need to introduce her because whoever available in our forums, they are familiar that how much Medal is active in the dental coding group, and she is also explaining or clarifying a lot of doubts for our members. She is one of the very active member in our dental coding group. I hope you all are familiar with her. And on behalf of all of you, I would like to welcome Medel to begin her session. Medel, the stage is yours. Please go ahead.
Thank you, Mr. Ahmed. That was such a kind intro. And real talk, I'm an introvert at heart, So I just learned to sound confident for work. But outside of that, you'll probably find me curled up with a book and coffee. But okay, enough of that. So hello, everyone. Good morning. If we hadn't met yet, I'm Madel Nucum. So I love solving a dental coding puzzle. There's something about the cracking the dental coding problems here, especially specifically here in UAE, Abu Dhabi. For me, it's like a real puzzle, and I try on, figuring out like the outs of all of it. And if you ask me what is my favorite area or dental department, it's hands down orthodontic and surgery, especially when it comes to implants. So, for me, there's a real satisfaction in getting those tools. So just right, So it's really great to be back as one of your speakers. So huge thanks again to Mr. Ahmad Sheikh, our amazing AEPC Abu Dhabi chapter president, for making this happen. So yeah. Um, Quick reminder, guys, if you're not in the AAPC Abu Dhabi social media groups, now is a great time to join. Maybe Mr. Ahmed, he can share the link or drop the link in the chat or the QR code, or maybe we can see that. So yeah, now I'm looking at my phone. I'm so happy to see familiar names. And if you're new, welcome, guys. So yeah, can you believe it's been a year since our last session? And I'm sorry I've been a bit of missing in action. If you see my WhatsApp message, I have like 3,000 radio each messages because life got really busy after June 2024. So some of you message me directly. Thank you, because you did not forget about me. But I wasn't able to reply to everyone. So I sincerely apologize about that. So because now in even more group chats, like WhatsApp group chats. Sometimes, I open the app, see a flood of notification, and just close it, like because it's kind of overwhelming for me, honestly. But being here today feels like catching up with old friends. So really, again, thank you so much, guys. Thank you for the warm welcome back. Okay, just a quick heads up before we jump in. If you're waiting for the PDF, just know it only covers the basics. So the deeper insights, real cases, and tips comes from today's live session. But no worries if you miss anything, guys. The replay will be posted on AAPC Abu Dhabi's YouTube, Telegram, and Facebook. Okay. Okay, so let's rewind to June 1st, 2024. That session was wild, right? So we covered the orthodontics, the pedodontics, and squish in prosthodontics. And I think I even tried to sneak in implants at the end, right? So what should be a 2 hour session turned into 3 hours. But honestly, it flew by because we were all so engaged. And yeah, I think the presentation was fun in my own opinion. So if you joined that one, um, thank you so much, guys. Now again, I'm scrolling in my phone and I already spotted some familiar names. And yeah, I remember the glitch during the orthodontics session around 44 minute mark. The audio overlap with Mr. Basharat's talk. So like there's a technical issue there, but I'm trying to re-record that session. And inshallah, once I'm done, I will send it to the AAPC to re-upload it again. But if you're curious, it's still on YouTube. So just search decoding the nuance of dental coding in Abu Dhabi, or you can just scan the QR here. So yeah, after that session, a lot of you asked, can we do a full session on surgery and prosthodontic? And then I replied, okay, if the AEPC will have me back, then I'm in. So here we are, and thank you again for having me. So this time we're kicking off the dental coding series. So split into focus session. So we're not rushing through everything. It feels like a TV show. No, there's a season one, season two, then maybe season three, right? So what I love is finally have time to go deeper into goals, share real scenarios, and not cram into one sitting. So personally, I enjoy coding surgical cases, especially implants, because they're so detailed and everyone feels unique. So if you're like me, today will be fun. Okay, so part one of our series focuses on oral surgery, periodontics, and prosthodontics, specialties that often overlap in complex cases. We'll look at the common procedures and real-world scenarios here in Abu Dhabi. And yes, we'll get into those frustrating insurance company quirks we all deal with. And so that's it. So we'll take a quick peek at the part two before we move on. So in part two, we will focus on pedodontics and endodontics, plus a deep dive into the recent changes in DOH COPA practice. So I'll show the side by side of the old versus new DOH COPA practice and how these changes are already affecting the billing, the insurance approvals, and system updates. So no confirmed date yet, but I'll keep you posted once AAPC finalize the schedule and of course if I will be able to finish it as soon as possible. So today, it's all about practical essentials from oral surgery, periodontics, and prosthodontics. Although we won't do line by line codes, guys, because we have a very limited time. We only have 2 hours. So I'll just walk you through our real scenarios and what actually matters, like the documentation, decision points, and the insurance workarounds. Okay. So for example, when it comes to surgery, things like simple extractions, cyst removals, or implants, I will show you how the documentation and also like the what you will put like the pre-op X-rays, the photos, they can all make a difference. The next one, the periodontics, it's gonna get more layered with things like bone grafting and regeneration, especially when department overlaps. It's not always a clean cut, guys. And then we will talk about prosthodontic, of course, the crowns, the dentures, the frameworks, whatever you call them, okay, and how implant related ones need specific privilege, like the implant privileges, restorative implant, all of these things, okay? And of course, insurance companies. the recovery notices that shows up months later with, without even a warning. You know who I'm talking about, right? So we're going to cover that, how to deal with them, what to document, and how to protect your clinic. So yeah, if you ever felt unsure about coding surgical and prosthetic cases or handling denials, these sessions got you covered. Now let's talk about how the treatment actually flows and who does what. It actually starts with an oral surgeon or periodontist. They handle the extraction, the bone graft, the membrane, and the implant placement. But here in Abu Dhabi, you must have the implant privilege from the DOH to place the implants. So no privilege, no placement, full stop, period. Okay. And then after healing, we can take about like 3 to 6 months or sometimes 6 weeks to 6 months, depends. The patient will return for surgical re-entry, usually by the same surgeon or anyone that is available there with the implant privilege. So that includes removing the screw and placing the healing cup, assuming that we are using the implant code of 7991. Okay. I'm going to discuss this more in detail in the next slides. So once that's done, the prosthodontist or anyone, as long as they have the implant privilege, um, steps into take impression and place the final crown, bridge, or denture. And yes, some GPs, with implantology diploma. I'm talking about like a 2 years course, okay? The one with the diploma, not just like, the simple one with the certificate. Those are different, okay? Because there is a GP with implant privilege and a GP with a postgrad diploma, okay? So that privilege can do parts of this, and but advanced surgeries like sinus lifts or complex implants, the GP cannot do that because that's a specialist territory. So throughout the whole process, guys, the documentation is everything. So remember that, okay? We need a clear documentation on clinical notes. We need the pre, post, and even during. If you can do that, do, okay? Pre, during, and post photos. The X-ray is very important. Whether it's bite wings, whether it's PX-ray, OPG, CBCT, anything, anything that can protect you during the audits and denials. So yeah, when everyone plays their part and documentation is tight, the treatment flows smoothly and the patient gets the best care. All right, before we jump into the type of extractions and billing, let's cover some basics for this part of our dental coding series. First, the mouth is divided into four quadrants. So the quadrant one is the upper right from teeth number 1 to 8. Quadrant two, this is the upper left quadrant, which covers the teeth number 9 to 16. Quadrant three, lower left quadrant, um, from teeth 17 to 24. And lastly, the quadrant four, which is the lower right quadrant, teeth number 25 to 32. So tooth removals might seem straightforward, but in coding, there's a lot more to it, guys. So from simple extraction to surgical ones involving soft tissue, bone, or sectioning, and even combine. So in this part, we're gonna break down the codes, documentation needs, and common challenges you might face. So let's start with the simplest kind of extraction, a fully erupted tooth that's just ready to come out. No flap, no bone removal, just skillful use of forceps or elevators, and out it comes. Okay. So when billing, use 71101 for the first tooth and 71109 for any additional teeth in the same quadrant during the same visit. Okay. So take note of that. The billing is during the same visit, okay, on the same quadrant. So, for example, the patient came and tooth number 6 and 5 get extracted, and they are in quadrant one, which is the upper right. So, you will code 71101 for tooth number 6 and 71109 for tooth number 5. So I often get asked by coders whether it matters which to get 71101 or 71109. Let's say my example was 71109 for the number 6, right? And then 71109 for the number 5. Now they are asking, can I make the number 5 the 71109, 71101, and 71109 for the number 6? My answer is no. It doesn't really matter because there's no official guidelines on the sequence on which tooth comes first, okay? Because we currently use tooth numbering system, the Palmer system for quadrants, and the universal numbering system for tooth number 5 and 6, okay? So again, for the quadrants, that is the Palmer system. But in DOH, we are using the universal numbering system for tooth number 5, like one from 1 to 16 to 17 to 32. Okay, now let's step it up. Surgical removal, or what do we call a dentectomy. This applies when the tooth is still erupted, but the dentist still needs to, lift a flap or section the tooth and or section the tooth. Okay, because it's a surgical flap and or sectioning of the tooth. So it means it could be either or both. Just give me a moment. I think I got lagged out with my phone. So yeah. Um but without bone removal, okay? So use 71201 for the first tooth and 71209 for additional teeth in the same quadrant. So important note for this code, for the 71201 to 71209, if bone remove, this is no bone, okay? So it's only like either flap or tooth sectioning and or, okay? So if bone removal occurs, we switch to advanced surgical extraction codes, which is 71211, okay? Now, in this code, now we're talking full surgery. Um, we're talking full surgery, more complex cases like severely decayed molars, roots fused to the bone, or fractured teeth. So in this code, the dentist raises a flap, removes bone, and may section the tip for extraction. Okay, so again, you will see the word and or. It means it could be both, it could be either. Okay, so you have to be very detailed in documentation. Includes exactly what was done and why, because these cases often undergo review or audit. Next is impacted teeth, starting with the easiest type, which is what is this one? Soft tissue impaction, okay? So that lies beneath the gums, but no bone blast extraction, okay? I think this is the simplest extraction for impacted, okay? So a small soft tissue incisions around allows removal. So use 7211 for the first tooth and 72119 for additional teeth in the same quadrant. If any bone is removed, it no longer fit this code, okay? Because this is only tooth beneath the gum or soft tissue. Okay, so for 72211 to 72219, this involves raising a flap and performing either bone removal or tooth sectioning, okay, but not both. So the tooth remains impacted, but is less complicated than full surgical cases. So use 72211 for the first tooth 72219 for additional teeth in the same quadrant. So if both bone removal and sectioning are done, we are going to use the next code, which is the 7221. Okay, 72221. Okay, this is the most extensive standard induction code. The dentist raises a flap, removes bone, and sectioning. So there's no or. Okay, so usually use this for difficult impacted third molars. So you will use 72221 for the first tooth, and for the same quadrant is 72229. Okay, so again, guys, I will remind you this billing is same visit. Okay, so for example, your doctor um, coded the 72221 on tooth number one, and then the patient came back again next day or next 2 days. He extracted tooth number two, then that's another 72221. Okay, not the 72229 because they are not on the same visit. So for these codes, you will include clear X-rays and detailed operation notes. Documentation is critical. Okay, so I'm just gonna share my experience during the man audit last few years from my previous facility. I do remember that the man did ask not just for X-ray. So can you believe that they don't just accept the X-ray? They needed the photo showing that this is really the condition. And so yeah, I think they got recovery. And not all of them they got defended because the X-ray was not present. I do recall they did. Yeah, I think they did they had a recovery that time. So next code is the impacted tooth unusual difficulties. I think this is the most expensive codes in the extraction. So sometimes the extraction is very complicated. There's excessive bleeding. The patients have restricted mouth opening. There's a curved roots on the tooth or medical issue, or even if it's near the sinus or inferior nerves. So those things, anything that that will put the dentist in such a difficulty. So you will use 72231 for the first and 72239 for additional teeth when such difficulties exist. Okay, so the clinical notes must clearly explain what made it unusually difficult to justify this higher code. Like say for example, the tooth is near the sinus, so that one it can defend this one. It can defend the code. Okay, so you might ask me, can anyone use this code? Absolutely not. My answer is the oral surgeon or the maxillo. I think even the periodontist can use this code, but they are not immune to recovery. Okay, because if they don't have proof to show the audits that, like let's say the photos, the x-rays, and the documentation, if they did not clearly explain what they did or what is the unusual difficulty that they faced that time, it's going to be subjected for recovery. So no one is immune in recovery. Okay? So that's why I keep on advising everyone to document everything, not just clinical notes. Photos, x-rays will save you guys. Trust me. Okay, been there. So last one is the residual root. Excuse me. So residual roots are, it could be a leftover root tips or a severely decayed tooth. So it got cracked and then, it became like our rated root. So it could be also, we will not use the word fracture. It should be like crack, okay? So a crack tooth with at least one wall remaining. Uh, this is not a residual root, okay? Like it has to be no walls left for you to consider it as a residual root. So it, if you see a cracked tooth with at least one wall left, then you will still consider that as an erupted tooth extraction, okay? So for the residual roots, what you have to remember, there should be no walls left, okay? Just the root remnant, that's it. So if the root is visible and can be removed by forceps or elevator, this is the simplest code for the residual root. Okay, so 72311 for the first, and of course 72319 for additional roots. If not visible and requires flap, then you will use the next code, which is 72321. Okay, so when the root lies under soft tissue but bone is intact, flap is raised but no bone removal. This is the surgical, but less complex. Okay, so you will use 72321 for the first root and 72329 for additional roots. So if the root is buried beneath bone, this is a full surgical case. Okay, the dentist must raise a flap and remove bone to extract. You will use 72331 for the first and 72339 for additional roots in same quadrant. So again, just like any other extraction folks, we need an X-ray, we need photos, even for the removal itself. Okay, once you remove it, you have to have a photos the post of extraction, and then you have to clearly document it in the clinical notes because that will justify and help you in audits, not just in TASMIF, but in insurance company audits. Okay. So let's dive deeper into cyst removal and alveoloplasty, focusing on when to code these procedures during or after extraction, using the right codes and understanding clinical scenarios. So first, enucleations of cysts or granulomas, you will use the code 74611 through 74616. So these cover cases where the cyst or granuloma is, removed along with some bone tissue and the site is sutured afterwards. So the code range by size from 1 centimeter and under all the way up to 15 centimeter, which can only be done by, let's say, the periodontist and oral surgeon or even the maxilla. So anything above 1 cm, it has to be done by the surgeon, oral maxilla, or periodontist. Okay. Below, it can be done by GP with implant privilege. But make sure that all of these things are, in the internal clinical privileging. So this procedure, can happen during an extraction if a cyst is discovered and needs to be removed at that time. However, guys, it's important to note that if the cyst removal is minor only, or it only involves a soft tissue without bone removal, or if it's granulation tissue left after an extraction, please, guys, remember, you shouldn't code enucleation separately, okay? Because that's typically included in the extraction code. Next, there is, it's really hard for me to um, pronounce this one. So excuse me if I am gonna pronounce it wrong, okay? Marsupialization. I hope I got it right. So with codes from 74620 and 74621. So these procedures, like creates a surgical window in the cyst to relieve pressure and allow it to drain. Okay. So usually, when it removes, it's too risky. This can be like a standalone procedure or part of a stage approach, often done before definitive cyst removal. Okay. Then what is this? Okay, yes, the excision of cyst. We use the code 74631 to 74638, which also no, scale by size. So excision is a bit different from enucleation, okay? Because typically involving a complete removal of cyst without prior bone removal. But the size and complexity, it matters, guys, okay? Now, about alveoloplasty, okay? This is the surgical reshaping of the alveolar ridge, okay? The coding depends on timing related to extraction. So, for the code of 73111, when alveoloplasty is performed in conjunction with extraction. So, typically on the same surgical visit, and it's per sectant, okay? And then you will use 73121 if the alveoloplasty is performed separately from extraction. So, often weeks later after initial healing, also per sectant, okay? So it's critical to, document clearly if the alveoloplasty was done during or after an extraction, as excuse me, as this dictates the correct code. So minor smoothing or light contouring of bone at the time of extraction is, it's considered part of the extraction fee and of course not billable separately. So for more specialized cases like the code 73141 and 73142, this is a cover bone remodeling of a myeloid ridge and genial tubercle. I'm really sorry if I'm, pronouncing it wrong. So yeah, these are the rare and should only be used when there's a clear prostatic or functional indication. Okay. So remember, guys, feel only what's medically necessary, and you have to fully document it. Of course, again, I will remind you over and over again. Take photos, take X-ray, document it in the clinical theory. Okay, clinical notes. Okay, because this proper clinical notes, this will save you. So you have to include the size, the location, what is the type of the cyst, the presence of bone removal, and the timing. I'm not talking about the start time and end time, guys. Okay, I'm talking about like the ones in the alveoloplasty, if it's done during the extraction or without extraction. Okay, because they are essential, for justification, not just a justification for approval if you need to send approval, but for overall, for when the audit comes. So by carefully, selecting from these code ranges and documenting clearly, you will help ensure accurate billing and reduce denials, and of course, recovery. Okay. So are you ready for the next topic? We are going to move to implant coding, which is my favorite. So we're all in this preparation. Let's do, restoring beautiful smile. Sorry. Okay, now that we extracted the tooth, maybe, I don't know, maybe we remove a cyst or we don't. So we're going to enter now to one of my favorite areas in dental coding, which is the implant. Okay, I really love implant. Other than I know, aside from the orthodontics. So before we get excited with all these codes, let me give you a friendly, real world warning. Okay, so guys, please remember, implant coding rules can change suddenly. Well, not just implant, like in general. Okay, you know, I don't know. There's something weird about the insurance company that I'm sorry I cannot say who, but who am I talking about? You won't get a circular. They're just gonna start rejecting claims or recover the previously paid claims. Because I remember during the last presentation of orthodontic in AAPC last year, June 2024. A few months later that, there is a rejection. So no notice at all, just a denial and a new headache for all providers. So if that happens, please hear me out and here's my advice. And honestly, this gonna applies not just to implants, but even to basic stuffs like scaling, polishing, or multi-surface fillings, like literally like every coats or so you have to take the intraoral photos or even digital photos, capture the X-ray before and after, and yeah, write proper detailed clinical notes. Because when the audit time comes, and yes, they will come. Trust me, they will come. These are the only things that will protect you. And if your clinic has ever faced a recovery, you know exactly what I mean, guys. So now let's go back to implants. Implant coding isn't just one screw, one code. It's really like a clinical story. So it's first tooth loss. It could be um, it's already lost or it has been extracted. Then we will do the bone graft, then the membrane, then we will place the implants, then healing abutment, then final product. Okay. So each one of these steps must be medically necessary. It must be coded correctly. It must be documented clearly. Okay. So fun facts, guys. Bone grafts and membranes, they are not always for implants. It's not by default when you hear this GBR or GTR, you will think that, oh, the doctor wanted to do implant. No. Okay. So sometimes the membranes, they are used after the cyst removal or tumor curettage, to protect the soft tissue and support healing. And that's totally valid, and the insurance will approve that as long as you have medical necessary and it's documented and there's x-rays and photos, okay? But for today, let's focus on implant related coding only because there's already so much to cover, okay? So before we dive deeper, um, let me define a few key terms you'll hear throughout this session. So the real site definition according to CDT or the current dental terminology, if two teeth have their own separate bone defects, then that is two sides. Okay. If two teeth have connected communicating defect, that's considered as one side. If there are two non-adjacent missing teeth, each is a separate side. Okay. So up to two adjacent missing teeth, still considered as one side. More than two adjacent teeth may qualify as two sides depending on separation. That is kind of overwhelming, right? I did not, I cannot even, memorize it. So we will just focus on the man and tika, like what is the definition uh, from the man and tika's perspective. So they will approve bone grafts or membranes only with at least three teeth gap or two teeth per quadrant. Because we have two quadrant right per arch. So upper right, upper left, then lower left and lower right. So four quadrants, two quadrants per arch. So for example, your doctor wanted to do a grafts on tooth number 2 and 3. You will have a rejection, or even if you will accidentally get an approval, it will be recovered eventually, or it's gonna get rejected on claims level. Okay, so how are you going to send an approval or bill for that? Example, you will have to ask for approval for bone grafts tooth number 2, then tooth number 6. You see, it's a treated gap, okay? You're asking for tooth number 2, then number 3, 4, 5. That is the three teeth gap. Now you will be eligible for tooth number 6. And then again, 7, 8, 9, three teeth gap, then tooth number 10. Okay? So this is not always written in guidelines. This is from, real rejection, real recoveries, and real experience. Okay. You know that. Like they don't give you guidelines. They're not gonna send you circular or, like release a guidelines that this is our, you have to follow these rules. No, it's not, it's not always like that to, which insurance I'm talking about. And then we have the osseointegration. So this is the healing phase after the implant is placed. It's when the bone, fuses to the titanium. It usually takes to 3 to 6 months. So depending on bone quality and the patient's overall health, okay? So what if the integration fails? There could be a peri-implantitis. There could be, so much more. So the implant can become mobile, or there will be a mobility, or even fall out. So the most likely the doctor will remove that, probably replace if there is still bone enough. So that's why don't rush into crowns, okay? And finally, a very important compliance reminder: just because your doctor is a periodontist, oral surgeon, or maxillofacial, or even, a GP or any doctor with 20 years of experience, it does not mean they're allowed to build implant procedures in Abu Dhabi. Please remember this, guys, okay? They must have a DOH implant privilege listed under their license, okay? So no privilege, no implants, full stop. So this isn't just a rule, it's about billing integrity also, and, staying compliant with regulatory bodies. So we'll talk more about how privilege affects coding and authorization later on. But for now, let's decode the implant journey step by step, okay? Oh, sorry, there is a slide. I forgot. So just take a quick look over this before I move on. Okay. Just hold on. Okay, so let's clarify a word we hear a lot: transmucosal. So what does it mean? Trans means across and mucosa means gums. So transmucosal, this simply means across the mucosa. Okay. Anything that sticks out above the gum. So if you look into the mouth and see a shiny part of the implant sticking out, like a healing cup or an abutment, that's a transmucosal component. Okay. So clinically, it's very important, okay? If there's no transmucosal element, the soft tissue may close over the implant, okay? So the doctor will require a surgical re-entry again. So when we say transmucosal element, think of healing abutments, temporary abutments, or final abutments, okay? All serve to maintain, access to the implant during healing or before the crown. So, what is the transmucosal element in simple definition? It's part of the dental implant that sticks out through your gums. Okay, remember that. And it connects the metal implant in your jawbone to the fake tooth, which is the crown. Okay. So, real life example, healing abutment, which is that 7934, right? So this is a small metal cup that is screwed into implant after surgery. Also in 7932, by the way, you will see that the implant and then healing abutment. So it comes up through your gums while your bones and gums heal. Okay, so goes through the gums again. That is transmucosal. Okay, So, what does healing abutment do? It helps shape your gum tissue before placing the final tooth. It's temporary, but it's good example of a transmucosal element. Okay. Also, the final abutment. This is like the small metal post that is placed in the implant and comes up through the gums. The crown, the fake tooth is placed on top of it. Okay. So the most common transmucosal, this is the most common transmucosal element in implant. Okay, implants need solid bone, right? So you can't place a screw into sand. So we use bone grafts when the bone is too soft or too thin, or there is atrophy, like literally boneless. So autograft 42611. This is the patient's own bone, often collected during drilling. It's the safest and most effective, especially in small amounts. Then we have the allograft, which is 42621. This is a human donor bone, okay? Like, I think the most common brand here is the Cinnabone. This is the commonly used in UAE, especially in Abu Dhabi clinics. Last one, we have the xenograph, and the code is 42631. This is an animal-based bone, like the brand is BioOS, I think. So it came from a bovine sources, okay, like the cow. So you will only bill per site. That means every 3 teeth. You remember my examples in my previous slides. So, for example, you did or send an approval. So, and you will claim. So, tooth number two, then tooth number six. Okay. So, if you violate that spacing, of course, you have to expect denials, rejection. Even you get approvals, guys, it will get denied in claims level, or even if it get paid, it's gonna be recovered later. So, of course, my advice or my tip is take surgical photos during when the doctor is putting the bone graft, like this picture. You have to log the serial numbers. You and then you will stick the label in a logbook. So buy a logbook, guys. Seriously, this save us in insurance audit. So also remember this, guys. If you are billing a sinus lift on the same tooth, don't build a separate bone graft, okay? Unless it's a different location. But we're gonna discuss more on that later. So, for example, the doctor asks for a sinus lift on tooth number two. You cannot bill again the any of the bone graft, okay? You have to choose either sinus lift or bone graft. But for example, the doctor asks for bone graft on tooth number two, and then sinus slip on 14. That one is fine because they are on different side. Okay. So if you're working in the upper molars and the bone is thin, the sinus might be um too close for a stable implant. So what does the doctor do? The doctor will lift the sinus membrane and pack bone under it. Okay. So if the bone height is lower than 4 millimeters, they are going to use the open lateral sinus lift. But if it's greater 5 mm, the doctor will do the crystal indirect sinus lift. Okay, so those are the codes. So 79351, 79352, 79353 for open lateral approach. So the first one is the autograph, second allograph, and xenograph. So basically, like the last digits represents like what type of material they are using. Okay, and then of course for the indirect inferior approach, sinus lift, it's the same. Okay, so the code is 7935. I no no I'm sorry. 79354, 79355, 79356. Okay, so 456. So you see, it changes the material. So again, like I said, the sinus lift already includes bone grafting. So don't build bone grafts again on the same side because it will get rejected. Even if it get paid, they will recover them. So after placing the bone graft, of course, the doctor doesn't want the soft tissue collapsing on it, okay? So we will place a membrane to shield it, or the doctor, not me. So resorbable membrane, the code is 42702. It dissolved naturally, okay? So no removal needed. So you might ask, oh, is there a removal? We're gonna go after that, okay? Later, I'm sorry. So non-resorbable membranes, 42701. This one needs to be removed surgically. Only if removed in a separate visit, that's when you can build the 42703. But guys, please, I will be very brutally honest with you right now. I've never ever used or advised 42703. Maybe because I have never seen any doctor use this non-resolvable membrane in my entire career. So, and also for me, I think most insurance bundles the removal of the initial code, but you can try, guys. And you have to write your case or justification like a court case. So if it get rejected or recovered, please make sure to share it with us or me. So maybe inshallah in the future, AETC presentation, I can share it to everyone, right? So yeah, document what type of membrane, if it's resorbable or non-resorbable, how many grams, or I don't know the measurement or size. But it doesn't matter. I don't think it did matter, for the size or how many grams. But for me, what is the most important is, of course, buy a logbook, log the membrane sticker, write the brand in the clinical notes, guys. This is very important, okay? Like for example, for the membrane, I think the most commonly used is the Jason brand or BioGuide. So whatever it is, just stick, the membrane sticker to the logbook. And don't forget, guys, this is very important. And I've got a lot of questions regarding this. If, for example, you ask for a membrane approval, let's say for tooth number 2, and you get an approval amount of 1,470 dirhams, you don't call the 1,470 full, because you have to divide it into two. So 1,470 dirhams divided by 2 equals 735. So guys, you will only bill 735 dirhams, okay? Because membrane codes are half billing as per FICA guideline. I think also this also applies to other insurance. You're gonna have to divide it by 2. I think so, okay? Because honestly, I haven't encountered any membrane or bone grafts approval for other insurance company other than Daman or Sika, okay? But of course, for Daman, it's not 1,470. I cannot recall. I think it's 1,160. I don't know. Correct me if I'm wrong. But anyway, whatever the amount is, you have to divide it, okay? So same three-teeth rule, same as the bone graft. It also applies the same treated rules here in membrane. So spacer membrane request properly. Anything closer may trigger, a rejection or audit later. Same what I said earlier in the bone graft. So tooth number 2, 6, 10, 14. Like it doesn't have to be the same tooth like that. Okay. So for example, your doctor asked for tooth number 4. So just count 5, 6, 7. Then the next one is 8. Okay. I'm getting tired now. Catching my breath. So, all right, now comes the main event, implant placement itself. So let's break down the codes step by step. 79931. I think this is the most commonly used, right? This is, the implant with the cover screw. So the implant is fully buried under the gum. It's invisible after the surgery, because the doctor closes the tissue over it completely. So this means the patient must come back after healing for a second surgery. We call that surgical re-entry. So you will use the code 79934, 79935, or 79936 for that later, okay? Then we have the 79932. I think this is the second popular one, right? So this is implant, and that includes a healing abutment. So it sticks out through the gum. So no need for surgical re-entry. But yes, you will need to still place, a final abutment or mesostructures later. Then the third one is 79933. Now this is your one-stage multi-component implant, okay? Someone's calling me. Sorry. So 79933, this is the multi-component implant. So the final abutment is placed at the same time of the implant surgery, okay? So no need re-entry, no mesostructure needed. You just have to wait for healing and move to prosthetic phase, okay? Then the last one is 79941. This is a one single component implant system, okay? So basically the implant and the abutment are one in solid piece, okay? Nothing to attach later. It's commonly, used in situations like limited space or when the bone is put in for, wider components. So what is the difference between 79933 and 79941? So with 79933 is modular. The abutment, is a separate part that's attached during surgery, while the 79941 is all-in-one, okay? It's like a solid unit that functions as both the root and the neck, just like this one in the image. So now your question is, when would the doctor choose 79933, 79941 over 79931 or 79932? I don't know, they're the doctor. But kidding aside, usually when they want to avoid second stage surgery or when they are planning for early loading, or especially, in patients with strong primary stability, meaning the implant achieve, the high torch, which is greater than 35 Newton centimeter, Um, I don't want to discuss that. I'm not really familiar with this torch. So anyway, 79933 or 79941, this is the early prosthetic work is possible, if the conditions are favorable. So in 79933 and 79941, since there is already an abutment, you can put provisional. But I will discuss about the billing guidelines about the provisional, okay? So we're just gonna focus now for the implant. So now a few hard truths based on my experience or audit life. So max 6 implants per arch. That's it, okay? Which usually means 3 per quadrant. So sometimes the doctors are doing 2, 4, 6 or 3, 5, 8. So that is three teeth already per quadrant, right? And then they're gonna go on the upper left again 3. So if you go beyond that and still get an approval, don't celebrate, guys. Don't celebrate because they will recover it later. Second one is the third molars, which is the wisdom tooth. This is not indicated. Okay. Even if you somehow got approval, trust me, I've done it before and I warned the previous facility 100 times that the insurance will recover it. I told them that, okay, sure, I will do the impossible. I will get the approval, but you will be paying for it eventually. You will get recovered for it. So same thing with three adjacent implants. So now we're gonna focus on Raman and Tika. For the three adjacent implant, as per their guidelines, it's not allowed. And again, in my previous facility, they did not listen. So a few years later, they got lots of recoveries. Okay, because they think that just because they got an approval, it means that the insurance company allowed them to do this. When it's clearly stated in their guidelines that three adjacent implants can never be covered, or as per TICA guidelines, you know, um, it's not accepted even if it's medically necessary. So yeah, they got lots of recoveries. And we're talking about six digits recoveries, okay? But here's a hack, okay? Tell your doctor to okay, now we're focusing on three adjacent implants, okay? I'm gonna give you a hack or a pro tip. Tell your doctor to ask the patient if one of those implants was done outside Abu Dhabi, or maybe one of the implants is done by cash. If yes, that's your justification in the approval request. That way, only two will be considered under the insurance, and then no, one of them, and the third implants re-entry. No, sorry. If for example, sorry, I got confused. If for example the patient said no, the two implant I done it under the man or Thika, then the third implant re-entry, uh, either ask the patient to pay by cash or the doctors will give it for free. And then you can ask for the implants re-entry for the third implant, okay? And then mesostructure and then crown, okay? Let me just take a breath. Okay, again, just like I'm always saying, this might work for now. The tip that I told you about, like the loophole for the third implant, this might work for now, but maybe a few months or years from now, the insurance company might change the rules again, even without, releasing guidelines or circular, then they will recover. So, but in any case, like for example, this one, the third implants three and three mesostructure. For example, your doctor asked the patient to pay the third implant or give it for free. Since there is no official guideline yet on the third implants re-entry mesostructure and crown, just in case, guys, you get a recovery or a rejection, you can still defend it, okay? As long as the doctor did it with medical necessity and the documentation is there, we need the post photos, digital X-ray, etc. So just you can still justify it, because there's no alert yet. There's no alert, okay? There's no alert that they are not allowing the cash for the third implant, three and three mesostructure and crown during the second stage. Because the only alert that we are receiving, especially in approval request, is for more than six implants per arch or three adjacent implants. So implants, but they did not say about three and three mesostructure and crown. So there's no circular yet. So yeah, if the patient paid the third implant by cash, why make the second stage re-entry meso and prosthesis part free, right? Doesn't make any sense. They have to cover it. Not unless, of course, they finally release a prosthetic guideline that clearly says it's excluded. That's a big inshallah, All right, now let's talk about surgical re-entry, which is only applicable if your implant was done with the cover screw 79931. This code is the only one that has a surgical re-entry, okay? 7993. So a few months after the implant is buried and has healed, the doctor goes back in surgically and places a transmucosal element. This could be a 79934, which is the healing abutment, or sometimes I think they call it healing cup, just to shape the gum. Then the 79935, this is the one with the final standard abutment. It's a surgical re-entry also. And 79936, surgical re-entry with final custom abutment. Plus L means lab fabricated. Okay. Now here's the catch most folders miss, and it's a big one. They are not always the final abutments. Okay, especially in anterior cases or long span bridges, the doctor might place a 79935 or 79936 just to hold a temporary tooth for, probably cosmetic reason or gum training, and later remove it, once the tissue has matured. So clinically speaking, this is called a provisional abutment. Okay, after they remove the screw, they will either put 79935 or 79936. And this is normal, guys, because soft tissue around implants, needs time to shape properly for the final crown, okay? Because according to Mish Contemporary Implant Dentistry, these provisional abutments are for aesthetic contouring, but they are not ideal for long-term functions or aesthetic. So they are replaced later with a proper mesostructure. And this is where coding goes wrong. Excuse me. So if you build 79936 and later you will build, let's say, 26102, insurance might say, well, you already placed a final abutment, right? Why are you billing another? So please, if your doctor places a temporary abutment, surgical reentry with a, temporary abutment, 79936, which is the final custom abutment lab fabricated, and it removes before placing the 26102, make sure in the clinical notes you will say this, okay? Write something like 79936. No, don't say the word. Like surgical reentry, final costume abutment was placed as a provisional. If you can make it caps like, do it, okay? So yes, surgical reentry final custom abutment placed as a provisional and will be replaced, okay, with final prosthetic abutment. If you want to make it caps lock for that title itself, or for the procedure name itself, do it, okay. And always, again, take photos. If they have a lab serial numbers or a lab bill, just file it or upload it in the patient's file and explain the clinical sequence, okay? Okay, so now let's talk about the real final abutment. Okay, the other one, the previous one was surgical re-entry with temporary abutment, because that one is they are using it for temporary restoration. Okay, so yes, real final abutment, the one that actually holds your crown long term. This is what we call the mesostructure. Okay, we have three types, and yes, the coding depends on how it was made. So first one is the 26101. This is the indirect prefab angle transmucosal. Okay, so this is often used when standard parts will do the job. Second one is the 26102, which is the indirect costume lab abutment. Again, there is L on that. So this is for those tricky aesthetic cases like, you know, tilted implants or anterior zone. Again, plus L means a lab was involved. And lastly, we have the 26103, which is the chair side of direct chair side intraoral shaping. So chair side fabricating abutment, this is made directly in the mouth by the dentist. Okay. Now, here's the big reminder. If your doctor placed 79935 or 79936 earlier here as a surgical, oh, no, wait, sorry, this one, 79935 or 79936, he or she did the surgical reentry using either of those codes, you can still bill 26101, 26102, or 26103, any of those three, but only if they were separate, okay, like distinct components. So how do we prove it? Of course, documentation, okay? In your documentation, like I said earlier, you will mention that that one, the code, the surgical reentry final abutment was used as a temporary provisional abutment, or let's say aesthetic soft tissue contouring, and then the final custom prosthetic abutment was placed at later visit or will be placed later visit. Okay. Again, guys, photos. If they have serial numbers, put it. Love, all supporting cases. So let's be real. If insurance say both codes with no explanation, not just this mesostructure or surgical reentry, like in general, they will recover them. Okay, so we have to be clear. Like for this scenario, one was temporary, and the other is the final one or definitive. Okay, so real case, tooth number two, sinus lift case. Okay, so let's break it all down with a full blown clinical case. A real world scenario, for the number two, let's say this is the upper right second molar. So, clinical background. CBTC showed that the bone height was less than 4 mm. So the surgeon, decided to do, let's say, the open lateral sinus lift, and he or she built the bone up for, a strong implant foundation. So how do you code it? 42601, let's say, uh, the surgeon did the allograft using the sinew bone. But again, you remember what I said, right? The sinus lift and bone grafts, you cannot build them both together. So since the bone graft is already included in the sinus lift, you can build it with zero amount. The bone graft, you can build it by zero amount. Why? Because you have to report it, for the DOH reporting purposes. You still need to log the material. You have to write the material. And yeah, it's like a justification that you did not do a double billing. Okay. Then, assuming the doctor did the resolvable membrane placed on tooth number two with Jason brand, then the surgeon put or the nurse put the photo serial number stickers in the logbook. Then 799352, the surgeon did the open lateral sinus lift with allograft. So CBCT attached with annotation that the bone height is less than 4 mm. So guys, for the CBCT, you have to attach the four views, okay? Is the 02934 code is for the four views. So you have to attach the four views related to what your doctor is doing. And also you have to document, the four views, not just say in the documentation CBCT taken. Like what is that? Okay, it's not valid. So you can either bill this sinus lift by full amount and put the 42621 or the bone graft, any bone graft at zero amount for DOH reporting purposes, or you can flip it. You can either bill the bone graft and make the sinus lift free. Just don't bill both, okay? Now, if you're gonna ask me personally, I'm gonna be real with you guys. If you ask me which to bill, honestly, it depends what gets your better approval, or like if they will get paid or if you get approval. But sometimes, honestly, it's smarter to give up the small amount, which is the, let's say for this case, the bone graft, And I will bill more expensive sinus leave. Okay, strategic billing, not overbilling. It's not fraud, by the way. It's not fraud because both of them, the doctor really performed that service, right? So you have to give up one of those procedures. So for me, in this case, I will give up the bone graft and I will bill the um, sinus leak because it's more expensive. And then the doctor did the implant with cover screw, let's say Stroman, BLX 4.1 millimeter by 10 mm. And then the patient came back after probably a few months, 3, 6 months. I think the earliest is 6 weeks, right? Or 8 weeks. Correct me if I'm wrong. It it really depends on the the healing process of the patient. And then they build the 7934, place healing abutments. Patient came back after probably 1 week, and then the prefabricated angle mesh structure abutment was placed. The code is 26101, and finally 27205 final zirconia crown seated. So all photos taken pre and post, CBCT attached, serial numbers and product stickers documented in logbook. So that, my friends, is always what you call, a clean, defensible, and audit-proof case. But in reality, it's about narrating the clinical story and making sure your documentation backs every step. And if someone's tell you just submit it and what happens, don't. This is a dental coding, okay? It's not a raffle, guys. So you gotta plan it right and from day one, okay? It's already 11:22, so I might probably skip some, but let's cover this one because this is a very important part. Okay, so now let me tell you one of those most common things I've experienced and what I know many of you ask all the time. How do I claim CBCT if the tooth is still present but the doctor is planning an implant? Okay, so let's break it down. Let's say the patient has tooth number 2 again. We're gonna stick to that case earlier. Unrestorable due to irreversible pulpitis. There's also a moderate bone atrophy in the maxilla because tooth number 2 is maxilla, right? So the doctor decides, okay, we'll extract it and place an implant immediately. So the doctor performs a CBCT and claims it with Kaiser 8 point, IK 4.02, which is the irreversible pulpitis, and Kaiser 8.25 for moderate atrophy of the maxilla. Then my team submitted an implant approval request with Kaiser 8.433 partial loss due to caries, class 3. That is the planned future state, okay? And Kaiser 8.25 moderate atrophy of the maxilla plus the Kaiser 8.02, which is the reason for extraction. Um, this is correct, okay, because you're asking for an implant later on, even if it's not extracted. You can easily write in the justification notes, for example, you're asking for a demand or THICA approval. You can just say tooth number 2 is unrestorable due to deep caries leading to irreversible pulpitis with moderate bone loss maxilla. So extraction and immediate implant will be done. This is the correct way because at the time of the CBCT, the tooth is still there, right? So you can't assign a missing tooth code yet because the doctor is still planning. You remember in the circular it says that it has to be about the implant cases, complicated implant cases, and implant what is that impacted tooth, right? So of course, when you submit the CBCT, it will get rejected because you have no partial missing or any tooth loss code or any impacted. But here's the part, what I want you guys to understand. Honestly, I don't know if the Man Ortica insurance super aggravating is like maybe they program the system to automatically reject any CBCT that doesn't include, a missing tooth diagnosing code or impaction code. Or, of course, maybe they just want us to manually resubmit it with more attachment and justification. But I know I already expected the rejection. So what I did when I get the rejection of CBCT, when I used that, let's say for example, only K08.4, K04.02 reversible otitis and the moderate atrophy of maxilla, submitting the CBCT without the missing tooth, I just attach the photo. If you have, guys, just attach it. Okay. If you don't have, it's okay. Because what's more important is the CBCT image, and then attach the implant approval request also. Then I went back to resubmit the denied CBCT claim, and I attached everything, and it got approved. So CC has that. So yeah, even if you do, everything right and use a valid diagnosis code like K04.02 or 20 plus K08.25, the claim, may still get rejected because, like I said earlier, there's no missing tooth. But remember, guys, always remember this in present, okay? You can't assign a missing tooth code if the tooth is still in the mouth. It's still present, right? Because that's inaccurate and it can backfire on you. So the correct way to defend CBCT claim is again assign the present findings or condition of the tooth, and then include the approval when you resubmit the CBCT claim. Add all supporting documents you have: photo, X-ray, justification of the doctor. Okay, or you can clearly just justify it by yourself. So now that we drill deep into implant placement, no pun intended, so bone grafts, membranes, and healing abutment, let's move into the next chapter, which is the prosthodontic. So what happens after the implant heals? How do we move from a titanium screw to a fully functioning tooth? Okay. We now enter the restorative phase, which includes the mesostructure placement, also known as the final abutment, implant supported crowns, implant supported braces. And yes, later we will also cover restoration over natural tooth if we still have time, because right now it's 11:28. So let's begin by wrapping up the implant story, starting with the processes over implant. So before we switch gears to natural teeth, no, over implant, that way, in fresh your mind and coding flow remains connected. Okay. So now we begin restoring what we surgically placed, the fixed implant supported crown. Clinically, this step is done only after osseointegration, which usually take 3 to 6 months or 6 to 8 weeks, depending on the patient's bone quality, age, and healing status. You can't just, screw in a crown the day after surgery, unless we're doing immediate loading under, very specific torque condition. The one I'm talking about, the Newton, C, and greater than whatever it's that. I don't I don't want to, go deeper on that. So here's the most important coding distinction. You must select the correct code on, like the crown material, if it's acrylic, PFM, zirconia, cast metal, if it's temporary or final processes, whether it's done direct chairside or indirectly by a lab. So 27125 chairside temporary, often, placed right after re-entry surgery. 27115 to 27135, the acrylic temporary crown made in the lab. We have the 27205, which is the zirconia or pressed ceramic. Excuse me. So very aesthetic, for anterior teeth. Then we have the 27215 PFM crown. This is great for molars where the strength is needed. And we have the full metal crown. Yes, 27305. This is durable for bruxers or limited clearance. Okay. So important notes again. Always attach the lab invoice if your code less like plus L, okay? Especially for the lab made crowns. In your clinical documentation, you have to include the shape, the tooth number. You can also put the before and after photos. Or the most important thing is the after, okay? Then preferably, of course, the PA X-ray because you have to show the margins that there's no open margin or it's good fit, okay? Because according to the dental guidelines, which was released on May 23, I think 2024, the crown procedures, are expected to last a minimum of 6 years. So if poor cementation or choice of material leads to early failure, the insurance can hold the provider accountable. So they're not just gonna reject, the replacement of approvals. Even, for example, you get accidentally the approvals, they can recover the claim. So one more thing, guys, don't build provisional and final crowns on the same day. Okay, even though some insurance company don't have this restriction for implant supported crowns, insurance company are still recovering claims, when crowns are done too soon. So as best practice and as for my advice, leave a minimum gap of 6 months between provisionals and final crowns billing. And also reminder again, if the code isn't listed in the insurance company price list, even if it's in the DOH tariff, it's cash payment, okay? So same applies if it gets rejected in the approval. Let's say, for example, it's covered in the insurance, but it got rejected to, for some reason, let's say it's not indicated or yada yada. Okay. So yeah, always tell the patient before you do the cementation, even in person, okay? Because once you glute it, there's no undo button. Now, let's say your patient is missing two or more adjacent teeth. So instead of placing 3 or 4 implants, which is of course expensive and not always feasible, the doctor may place 2 implants and span a bridge across the gap. Okay, so I'm gonna give you a clinical scenario. Let's stick to tip number 3 implants. Okay, so implant at 12 and 14, then the pontic at 13. So final process is a 3-unit bridge. So retainer, pontic, then retainer. So how do we code it? So retainers is let's say the implant supported crowns, not the retainers. I'm sorry. So implant supported crowns from, let's say, no, sorry, I'm getting confused now. So yeah, we are on bridge now. So implant supported retainers 67205, let's say, for if the doctor is choosing the zirconia. So tooth number 12 and 14, 67205. So what about your Pontic? You can select based on the material, okay? The most commonly combo for the 67205 is 62502. That is also zirconia. So Pontic on put number 13, 62502, okay? So clinical tip, guys, use PFM or zirconia in the molar region for strength. Don't listen to me, listen to your doctor, but I'm just saying, okay? So for anterior aesthetic cases, most likely they are going ceramic. They are using acrylic Pontics, of course, if it's temporary or a healing phase. Um, I think that's pretty much it, right? But what is the common procedure or a common combination? Yeah, that's it. 67205, 62502. So for the billing, for the clinical documentation, you have to mention the tooth numbers, of course, And then like clearly stated which one is the retainer and which one is the pontic. So for our earlier example, you have to say, let's say you did zircon implant, a bridge retainer, 12 number 14, 12 and 14, pontic on 13. And you have to mention the shades, let's say BL1 or 823, whatever it is. Um, Include OPG or CBCT if you have. I think that's it, right? So even if, like again, even if it's in the DOH tariff, mandatory tariff price list, if it's not available in the insurance, you can always ask the patient to pay by cash. Now we're moving into removable prosthesis world where function and affordability meet. So these are, like implant supported dentures, also called over dentures. So they're life changer for fully edentulous patient, or like no teeth at all. Like doesn't have to be upper and lower missing tooth. Like even in in only upper or lower. Okay, so especially for those who struggle with like loose or unstable traditional dentures, but let's clear one thing up, okay? Over dentures are not traditional dentures. They mostly they are relying, not mostly, they are relying on implants for support, retention, or like stability, depending on the design. So the codes, cost, and the documentation are different. Okay. So the tissue born over denture, this is no attachment. The code range is 517 to 1251733. Yeah, this is final. 51821 to 51833, immediate. So supported by implants and soft tissue, no mechanical attachment like locators or bars. They may use coping crowns, for passive retention, common for low budget patients or minimal bone cases. Okay. And then we have the 51921 to 51933 with independent attachment or locator abutments. So the indication is like the notes that you should know about each implant has like a separate retentive element. This is very common in 2 to 4 implant setups. Okay, it requires locators, compatible abutments, and I think housing embedded in the denture. So I'm not really familiar with this. Okay. So sometimes, the doctor is advising this because, it offers good retention and, ease of hygiene. Then we have the with retentive bar over denture, like Balder or Hatter bar. The code range is 51951 to 51963. So this is a costume bar joins the implant. Denture snaps onto the bar, I think. And also it's used in full arts reconstruction, often by more than 4 implants, because this is more stable, better stress distribution. That's why some of the doctors are advising this to the patients. This requires a lab coordination and additional code, okay? We're gonna skip some because it's already time. So I'm just gonna give you an approval and billing tips. So always have a panoramic X-ray when you're sending an approval. Panoramic X-ray photos, before and after or with showing the healed implants, treatment plan with of course the number and the number of the implant. Okay, clear labeling of components if you want the locator or the loader bar, everything. Okay, also same thing in the documentation. And plus, you have to put the type of attachment, number of implants, position, like if it's maxilla or mandible. And also, again, I'm going to repeat it. If the code is in the DOH tariff, but not in the insurance price list, it's not covered. Okay. Or if approval is denied, even if the are it's covered, then automatically it's gonna be cash. Okay. Especially for complex cases, let the patient sign for financial consent before you proceed. So again, clinical reminder: locator, better hygiene, easier for all patient or elderly. Bar is better for distribution, aesthetic, fewer sore spots. Tissue borne, budget friendly, but may need more frequent relays. So yeah, pretty much that's it, right? So let's move to okay, this one. So what's the difference between dentures versus over dentures versus implant bridges? Um, I don't know how do we explain this one? I think it depends entirely. Oh, wait, sorry. I think it depends entirely on understanding, the clinic. Where was it? Yeah. So the traditional denture, it rests entirely on the gums, no implant support. It may cause sore spots or bone loss over time. Okay, but this is best for patients, that can't afford implants or are not medically eligible for surgery. Let's say those um, patients with uncontrolled diabetes. Okay. And then the implant supported overdenture rests partly on implants, two or more, partly on soft tissue. They may use attachment like locators or bars or simply sit over coping crowns. Okay. It's still removable by the patient. Improve retention, reduce bone loss, and better function. So when this implant supported overdenture is indicated, patient needs better stability, than traditional denture. Uh, Cost or bone volume doesn't allow for full fixed arch. And of course, hygiene access important, elderly or those with dexterity issue, okay? And lastly, the fixed implant supported or the FPD. Uh, this is permanently fixed with screws or cement. Requires multiple implants per arch, minimum of 4 to 6 implants. Yeah, it does not rest on tissue. It's fully implant born. Okay, so high aesthetic, best function, feel natural. Okay, so when it is indicated, if the patient has a sufficient bone and implant number for full support, patients demand a non-removable solution. Um, Good hygiene habits and dexterity, and long-term investment in aesthetic and chewing efficiency. Okay. So when the patients say, I want teeth that don't move, you're likely recommending a bridge. And if they say, I want something better than my old denture, but I can't afford fix, then over denture might be your path. Okay, let's move on. So now that we've discussed the implant placement and restoration, it's time to explore one of the most advanced and life-changing dental solution, which is the fixed prosthodontic frameworks over implants. So these are sometimes called the hybrid prosthesis, full arch implant bridge, or all-on X restoration. And unlike dentures, these are permanently fixed in the patient's mouth. The doctor is using multiple implants and either screws or by cement. And yeah, they offer patients a secure, functional, and aesthetically pleasing alternative to, like removable prosthesis. So let's take a closer look at the codes. So set 69811 or 69812. This is the fixed framework with acrylic and denture tape. These are full arch bridges, which are constructed using denture, teeth, and acrylic. So it's indicated in economical full art restoration or when lighter occlusal forces are expected. So the design resembles a denture, but it is permanently screw written on the implants. And they are often used in all four or all on six cases for odontology arches. And the next one is the fixed framework with ceramic or metal crowns. The code is 69821 for the upper, and lower is the 69822. So this incorporates, like highly aesthetic materials like PFM, porcelain fused to metal, polymer glass, or full metal crowns. Um, yeah, it offers, enhanced durability and superior aesthetic, especially for younger patients or those with, higher cosmetic demands. So this is indicated, when the patient desires a more natural looking restoration with, long-term wear resistance. So maxilla versus mandible is based on the last digit of the code. Like I said earlier, the last digit of one is for upper and two for lower. So what is the clinical indication for a fixed prosthetic framework? The doctor typically chooses it for the patient when the patient, like fully edentulous, like no teeth in or either upper or lower, and they are, sufficient implant number and distribution, like usually 4 to 6 implant per arch. Okay. Um, Primarily stability of implants. It should be greater than 35 Newton cm torch. Of course, to allow, for early or immediate loading because the fixed prosthodontic framework, we are doing it, for immediate loading. So the patient has a good oral hygiene. Of course, this is very important. There is a sufficient inter-arch space, and can commit to follow-up care. And the patient wants a non-removable solution because it's fixed, okay? And it's psychologically or functionally unable to tolerate removable dentures. So before we wrap up, I want to clarify something that's, often misunderstood and honestly frequently, violated in practice. So, guys, technically speaking, only prosthodontists are allowed to perform advanced implant supported frameworks, okay? Like the ones we discussed in my previous slide. But this is a big part, okay? Even if you're a licensed prosthodontist in Abu Dhabi, that doesn't actually, mean you can perform any prosthesis over implant. Probably the prosthesis over natural tooth, okay, they can do whatever they want or how many they want. They can do it. The prosthodontist can do it. But for the prosthesis over implant, there's a restriction, okay? Because according to DOH and insurance companies like the Magnetica, only clinicians with, like with explicit restorative implant privilege or implant privilege listed on their term license profile, may restore implants or, put prosthesis over implant, like crown over implant, bridge, like all prosthesis over implant. So no implant privilege, no implant prosthesis. Full stop, okay? Not even a single crown over implant. So this also applies across the board to general dentists and specialists. And yes, again, prosthodontists, okay? If you don't have an implant privilege, you cannot do anything that is related to implant, okay? So what happens when a prosthodontist doesn't have implant privilege? Well, if the prosthodontist doesn't have implant privilege, the case may be done by a GP with implant privilege as long as it's within the GP scope, okay? But for advanced work like frameworks of full arch or hybrid prosthesis, that still falls strictly under prosthodontist with implant privilege. So let's take, do we have here now? I think I forgot to add it on my slides. Okay, and just make it easier. So according to the man, by the way, they are still following the old scope. Okay, so I'm gonna discuss this according to their demand guidelines. Okay, general dentist, simple crowns or bridge, max 3 per arch in quadrant, normal occlusion only if implant privilege is granted. Prosthodontists can do complex anterior aesthetic full arch implant cases. And other like pedo, endo, special care, they are not allowed unless internal facility privilege or upgraded scope is granted. So final reminder, guys, again, I'm gonna repeat it. Just because a code appears in DOH mandatory tariff, it doesn't mean it's included in your insurance coverage, whether it's the month, FICA, NAS, Next Care, you name it, okay? So if you send an approval also and it gets rejected, it's not covered, which means again the patient has to pay by cash. No question asked, okay? So yes, as I always says, insurance denial equals violate revival. So to be honest, I don't think we still have time to cover processes over implant because it's already 11:52. Anyway, I already discussed that in my last year's lecture, so maybe we can leave it for another time. I've been talking since 10 a.m., so my throat, is officially out of service. I'm really tired. So before we close up our prosthodontic discussion, let's visit something I skipped in the implant section. This was originally in the implant section, but I moved it, and I know that this is the perfect time to bring it up. So we're talking about how to correctly assign ICD-10 CM codes or diagnosis code for approval requests involving implants or removable prostheses, especially when the tooth is still present. So I will just clarify the rule number one. I know our rule is don't code tooth loss unless it's already missing, but it's only applicable for claims. Again, let's say the tooth number two has irreversible toothitis and the doctor plans to extract it and place an implant. Of course, we will not use K08 point, let's say 433 in the claim, right? If the tooth has not yet been extracted. Like the ones I gave example for the CBCT billing, that the tooth has not yet been extracted again. But for approval, guys, you must describe the post-extraction condition. You're gonna use here the future diagnosis because the insurance is reviewing your request based on what the mouth will look like after the extraction. So future, okay, not just what's there now, okay. So yes, you can, and let's say you will use the Kennedy codes in the approval because that's the future state you're planning to treat. Okay, so example coding for approval request. So anticipated that for irreversible pulpitis due to the caries reach into pocket number two, you will ask for implant with diagnosis code of K08.433, uh, class 3 partial loss due to caries. Irreversible pulpitis because this is the clinical reason for extraction, and moderate atrophy of the maxilla to support the graft, okay, or sinus lift. So this coding paints, the full clinical picture. Why the tooth will be extracted, what condition will exist after extraction, and why prosthetic or surgical treatment is needed. So what codes you need to avoid when you're asking for implant? I'm just gonna say the three most commonly codes that is well known. K08.530, K08.531, K08.51. These are prosthetic defect codes, okay? They are not valid for extraction. So don't say that the, let's say, tooth number two has a fractured crown and it's subjected for extraction. Come on, guys. That's not valid. But if you say that tooth number two has fractured crown, and like there's no remaining structure, so like now it's technically cracked tooth. Okay, I know you cannot code both the fractured and the cracked, but what is the most severe one? The crack, right? So you can code the crack. So if the crack is the reason is due to the severely decay, you will use the due to caries Kennedy, okay, or like cause. But if the crack is like for trauma, of course you will use the trauma code. But if the crack is you don't know what exactly causes the crack, then you can use the nine, the other. Later I will discuss that one. So why Kennedy classification matters? The insurance evaluators want to see the type of the edentulous space, not just a tooth is missing. And especially, it's important for removable prostheses, RPD, full denture, like everything. So implant, it's also important for implant approval, sinus lifts, grafts, partial denture, design validation. Okay, so I'm just gonna make a recap for Kennedy classification. So class one, bilateral edentulous area posterior to teeth. No, class two is unilateral posterior edentulous area. And three, bounded edentulous area with teeth on both sides. And four, single anterior area crossing the midline. So match with the ICD 10 cm via 6 digit. No, the fifth digit is for cost. Let's say, like I said, the carries, which is number three, so K0 8.43. Okay, that is carries. And the sixth digit is the class. So we're talking about 433, right? So it's pretty much the same. So class one is number one, two, class two, like that. So it's very easy. So just a quick reminder, guys. I've been telling this many times, like million times. Never use unspecified class unless you absolutely have no data. Okay? Because come on, guys, you get an OPG, you get clinical notes, you have a CBCT. So how can we say we don't know the class, right? You can say the cause is unknown if the patient doesn't know how they lost the tooth or the doctor didn't write it clearly. So I'm going to simplify the Applegate's rules. One is to classify after extraction clinically. Two is ignore third molars unless used as abutment. Applegate rules three include third molars if used. Okay. Number four, ignore second molars not being replaced. Five, class equals most posterior edentulous. Like you will classify it from posteriorly. Other spaces is modification. We are not using modification in Abu Dhabi setting. So we are just, straightly coding class one to four. Okay. Uh, yeah. So attribute codes we have for the maxilla minimal K0 8.25, K0 24, K0 8.25 for moderate, and severe for K0 8.26, that is maxilla. And for the mandible, K0 8.21 minimal, moderate 0.22, severe 0.23. Okay, so how you will document that? Severe is, I think, less than, ano, think I forgot to, did I put it here? No, I did not. Okay. So I have a question that I get from Holder. What if the doctor is replacing an old prosthesis, either natural or implant? How you will code the replacing of an old prosthesis? You will code the primary diagnosis for you will code the reason for replacement as a primary diagnosis. Example, a fracture, or there's a open margin, or there is overhang. And the secondary will be the Kennedy class. Okay. But if there was no all prosthesis, like the patient just come in with, missing teeth and no all prosthesis was placed before, of course you will use the Kennedy class first. Okay. So final tips for approval coding. Describe the future oral condition, justify with CBCT or X-ray or justification notes. Of course, you will use the ICD-10 or diagnosis code Kennedy plus the cause, atrophy if you're asking for a bone graft or sinus lift. Follow the Applegate rules and avoid vague or unspecified codes, because if you have, more specific code, use it. Stop using unspecified, guys, seriously. So the better you narrate the clinical story, the easier for the insurance company to review it or evaluate it and approve it. Okay. So, all right. Well, we've covered a lot today, from extraction to grafts, sinus lift, implant placement, prosthesis option, Kennedy classification, ICD-10 diagnosis coding logic, and all the little details in between. I know it was intense, and I truly appreciate every single one of you who stayed until the very end. Now, I want to say sorry. I sincerely apologize that I wasn't able to dive deeper into processes over natural teeth. Don't worry, we already tackled that in last year AAPC virtual meeting, right? So yeah, I was not able also to discuss more on Kennedy classification and the example and variation, like how you will know that this is class one or two, something like that. Honestly, this session turned out to be, way more loaded than I originally expected. And yes, true story, I slept at 5 a.m., finalizing this for you because I was juggling work, audits, family, and this presentation. And June 21, it just came too fast. But even if I couldn't finish it earlier than I hoped, I'm really proud that I still showed up, and presented what I could. Um, with real life examples, honest struggles, and actual insurance logic that we all deal with here in Abu Dhabi. So I hope you not only learned something today, but also felt like that this applies to me and this is my reality too. So what's coming next on dental coding part two? This is coming soon on AAPC Abu Dhabi virtual meeting. We're gonna, talk about pedodontics and endodontics and comparison between the old versus new DOH scope of practice, like what changed, who is the insurance company who updated their guidelines according to the new DOH code, or who stay outdated. So if ever that I didn't get your question answered today, don't worry. We have a few options. You can email the AAPC Abu Dhabi, or even better, let's continue the discussion inside the dental forum on Pure RCM. Thanks again and also big shout out to Mr. Zari for building that platform for all of us. I will be there regularly posting answer updates and maybe even some, downloadable cheat sheets if you're lucky. So again, I just want to say from the bottom of my heart, thank you guys for showing up. You could spend this time working, running errands, or getting some much needed rest, but you choose to invest in your growth, and for that, I salute you guys. Until next time, this is Madel Nucum signing off from the Dental Coding Series Part 1, Oral Surgery, Periodontics, and Prosthodontics. Bye, everyone, and see you again on Part 2. Oh, wait, sorry, I'm sorry. We still have Q&A question. I'm sorry. I just really hope, I have energy and brain cells left to answer your question because like I said, I woke up 8 a.m. after sleeping at 5 a.m. So I literally only have 3 hours of sleep. So if I start sounding off a bit, just blame it on that, okay? But I promise I'll try my best, my very best to answer everything you throw at me.
Well, that's a very wonderful session, and this is going to be like a very useful presentation, and the video also once uploaded, this is going to help all our members. The depth of the knowledge and the more detailed information shared to the members, I hope this will surely help them in their day-to-day life. Actually, when they are doing dental coding, I will give the stage to Shimi, our vice president, to share the certificate and attendance link to everybody. And I would like to ask the members not to share this QR code or not to share the link in any of the forums, so that those who did not attend the session should not get the CUs. Okay, so we need to valid that integrity we would like to expect from everybody, so that once whoever attended, they can get the CUs for this one actually. Okay, I will switch on the chat. No need to give your member ID in the chat. Okay, first of all, use the form to fill the chat. Okay, thanks.
Thank you, model. This was a wonderful presentation. And